Okay, Rosie, over to you.
Hello, I'm Rosie Cardale. I'm a pelvic health physiotherapist, and today's presentation is going to be on the 6 to 8 week GP check, and what to consider from a sort of pelvic health point of view. So, for those that don't know, I've done a few teachings now with the BNSSG Training Hub. So some of you might recognise me, but if you don't, then yeah, I'm interested in, well, I'm a physiotherapist and I'm interested in pelvic health. So the way I describe that is anything and any of the functions, muscles, and joints from almost the ribs down to the tops of the thighs. And this area changes a huge amount during pregnancy. And so it's a really important part of the body and the things that we rehabilitate after a pregnancy and in that sort of initial postnatal period. I'm happy for you to ask questions throughout the presentation. So if you can pop them in the chat, and then Penny will field that and then ask me the question that you've popped in the chat. But there is going to be time at the end for any questions to be answered as well. So if you want to wait till the end, we can do that as well. So let me just share my page. So can you see that, Roger and Penny?
Yeah, absolutely.
Great.
Yeah, thank you.
So I've done a little bit of a brief introduction already, but yeah, I'm Rosie. As I say, I'm a pelvic health physiotherapist. It's, I think, a really important speciality and a really interesting part of physiotherapy. I came into physiotherapy from a sort of viewpoint of me wanting to go into sports and run onto a rugby pitch or something like that, which I've never done. But I joined and I did my sort of band 5 rotations in the NHS. I knew about women's health and pelvic health, but at the time I wasn't all that interested in it. I was much more interested in doing sort of sports rehab and musculoskeletal presentations. I then moved to Bristol and joined a private physiotherapy practice and became a physio part-time at the BRI as well. And I just so happened to sort of be rotated and rotate into women's health at the BRI, so at St Michael's. And I was then sort of starting to do more private courses in physiotherapy in women's health. And I just absolutely loved it. And what I love is sort of merging the two aspects of physiotherapy in terms of the musculoskeletal aspect and then the pelvic floor and pelvic floor dysfunction, and really helping and enabling women, particularly, to get back to sports and exercise when pelvic health might be their primary dysfunction or concern. I think it's a really important time in a woman's life, this sort of very early postnatal phase. Unfortunately, we don't get much support for education and sort of resources and help around that sort of early postnatal stage. And it's seen, it's looked at as this sort of 6 to 8 week GP check, I think is really, really important. And I do feel sorry for you as clinicians because you have to do so much in such a short space of time and you've got so many priorities. So everything that we're going to go through today isn't necessarily, you're not going to be able to achieve all of it within that sort of 10 minutes or 20 minutes you might see that woman. But it's just to sort of make you aware of some of the considerations that I might then be thinking about when I see a woman at 6 to 8 weeks. And some of the sort of questions or the things that I'm sort of considering are relatively simple to sort of implement or suggest from your point of view. So that's why we sort of came up with this presentation, to just help your clinical practice, really. So hopefully from today's session, you'll be have a bit more of an understanding about some of the more common postnatal issues that might arise and why they arise and why they're important to consider. Understanding sort of pelvic floor dysfunction and some of the risk factors for developing it, and really how common it is and why it should be a priority for every woman that has gone through a pregnancy. and understand and be able to implement some really early strategies that I think are really effective to just allowing that sort of woman in those first what I call the fourth trimester, which is known as the fourth trimester, those first 12 weeks to really just get them in a better and more optimal state so that they can then move forward over the next few months after that. So it is a really important check, this sort of 6 to 8 week GP check. The birth trauma inquiry, which came out last year, had some very interesting statistics come out of it, and we're obviously not talking exclusively about birth trauma in this presentation, but it is definitely something to be aware of and to consider. So they found that 25,000 to 30,000 women every year will have a sort of develop a post-traumatic stress disorder as a result of giving birth, which is staggeringly high, really. They also found that I think it was 83% of women felt that they didn't have enough information prior to giving birth about the consequences or what happens as a result of vaginal tears and the risk of sort of forceps and episiotomy. And that's actually the statistic that I find most staggering, is actually yes, this 6 to 8 week postnatal check is really important, but we should also be considering the sort of education that happens prior to women either getting pregnant or in their pregnancy, which is a discussion for another day. But yeah, I think this whole area is just lacking good quality information and research as well, which we'll find out as we go through. So I wanted to sort of just highlight why people may well be dissatisfied with their postnatal care. And this Lavender et al. Study found that actually people were most dissatisfied with their postnatal care with poor communication, midwife availability. I think this study was done in Sweden, and a lack of sort of emotional support. And also that sort of really important stage for supporting the transition from like to parenthood for women and for the partners and the families as well. So that's why, you know, you as practitioners can be really useful to just have a look and have a think about that woman as a whole. I know you've got priorities and sort of pillars that you need to be ticking off in your 6 to 8 week check with that woman, but it's just thinking about how they're communicated, how are they feeling as a person, what is their sort of emotional state like, and sometimes some just guidance on that, or flagging sort of where they might be able to get more support from can be really useful for that woman. And in France, this is interesting, and I don't know if you know this, but all women are offered this, I won't say it in French because my French is terrible, but it's sort of perineal retraining after childbirth. And it's been happening for a number of years, but every woman is offered 10 physiotherapy sessions to help with pelvic floor retraining, core strengthening, and just rebuilding their general strength after they've had a baby. And that is amazing. And I don't know the statistics of this, but it seems like that their sort of overall spend per woman later on in that woman's life and journey seems to be lower. So prolapse repairs, more pelvic floor input from a physiotherapist seems to be a lower spend than we have got in the UK. So are they being quite proactive with their healthcare rather than reactive, which is possibly our model in the UK? So the sort of area that we're talking about is predominantly the fourth trimester. I mean, you may see women, and I know that in some practices, the sort of 6 week check has been pushed more to the 8 week check, and you might sort of be combining seeing that woman with the baby's sort of immunizations around that 8 week mark. But this sort of first 12 weeks is a really sort of acute and subacute phase of healing for all the tissue that has changed. So if you think about tissue healing timeframes, which is a sort of principle that I would often put across to women, to sort of get them on board with why they need to look after themselves and why they might be following certain principles. Tissue, any tissue, and tissue that has changed, which we know tissue within our abdomen and within our pelvis and our pelvic floor and that whole sort of complex that baby sits on, has gone through a change with pregnancy alone. And whenever any tissue has changed, it will generally go through then a tissue healing time frame to help it to get back to, as close as possible, the state that it is more normally in. So 6 weeks is normally known as the acute phase of healing. 12 weeks is known 6 to 12 weeks is known as the subacute phase of healing. So that's taking birth out of the spectrum or the picture, should I say. So adding in then a vaginal delivery or an abdominal delivery, you've then got additional tissue healing to consider on top of the tissue that has changed from a pregnancy. So yeah, it's why women shouldn't be sort of back to normal or back to where they were pre-pregnancy at 6 weeks, because you've only just completed your very sort of acute phase of healing on its most basic level. You know, different deliveries, different ways that you birth are going to impact the severity or the extent of what that tissue needs to do within that first 12 weeks to get to a optimal point of healing. So one of the big things that we'll cover today is pelvic floor dysfunction and what it looks like and why you need to be considering it and what sort of births you might sort of consider it more so, or just have a little bit of a sort of flag raised to think that woman has had this type of birth. I might just be a little bit more proactive at my discussion with pelvic floor dysfunction with them because of their birth. So the anatomy of the pelvic floor is amazing. I would say that because it's my speciality, but it's this really amazing complex of muscle and tissues, sphincters, fascia, tendons that really sort of sit like a hammock within our pelvis. And yeah, they're really, really clever. They're much cleverer than we are as people, because they work for us all of the time. I always explain it like if you were to cough or sneeze, your eyes would naturally blink and you've got an autonomic reflex to close your eyes when you're doing that to protect your eyeballs from not popping out. And you've got exactly the same reflex within your pelvic floor as well. So it's working for us all of the time. And occasionally we might need to sort of engage it to bring it on a little bit more, to give us a little bit more support. But most of the time it knows exactly what to do and when it should be doing it. The gold standard of pelvic floor health is that you are only ever really thinking about that whole area, that pelvis, when you're needing a wee, when you're needing a poo, when you're doing either of those two things, or when you're having sex. So if it's on your mind, or that area is mapping on your mind more than that, then it might be that there is a dysfunction or a problem that you should be sort of starting to become aware of. You've got two different types of muscles within that pelvic floor complex. You've got superficial muscles, which are sort of more, their programming and their function is more for helping to close the orifices of the vagina, the anal sphincter and the urethra. And you've got these deeper muscles, which have much more function with creating like that upward lift and support. And they're the ones that move sort of anteriorly, so to the front of the pubic bone, and cranially, so towards the head, to lift and support all of your sort of abdominal mass, basically. Predominantly, the 70% of the muscle fiber is this slow oxidative fiber. So it works for endurance type activities. It works for us most of the time. And we have 30% of type 2 fibers, which are your much more fast oxidative or fast glycolytic, which are your sort of quick responses. So that's when we're coughing or sneezing or jumping or on a trampoline, and where that muscle sort of says, oh, I've got to very quickly work a little bit harder than I would normally to provide support to that tissue. So some of you might have done this before with me, but it's always good to have a refresh, and particularly for helping your clinical practice to help educate women to do pelvic floor exercises correctly. So we'll do a little bit of a pelvic floor practical session. You can join in if you want. Obviously, most of the computer screens are off, so no, the video is off, so you can't see anyone else doing this. But you, if you know what to do with your pelvic floor and how to engage it, it's much easier to then teach somebody else. And if you know what it feels like, then again, you can teach somebody else. So we'll do it sitting if you're seated. I want you to uncross your legs and sit quite nice and square in your chair. Just spend a few minutes thinking about relaxing your tummy and just taking a few nice deep breaths whilst I just talk you through the anatomy and what cues you might want to use to do a pelvic floor squeeze. So a lot of the anatomy for your pelvic floor is actually back and behind your back passage. So cues that help to engage that back passage are generally our better cues to use. So things like holding in wind or stopping yourself from farting is quite useful. The one that I like, which always gets a little bit of a laugh, is imagining that you're smuggling diamonds through customs in your back passage and holding them in place. Sometimes you can then bring that through and think about holding in through your vagina, or if you've got male anatomy, like thinking about one cue that is quite useful is nuts to guts, which isn't very nice, but it seems to work. So obviously we're going to be talking about more of the female population, but if you are a man and practicing this, then it just gives you an idea of that sort of feeling that you're getting. So you want to start nice and relaxed, and then you want to think about either one of those cues, so holding in wind, holding in your diamonds, and then trying to draw that forward to your vagina or your urethra. So give that a go. When you do that, you want your tummy and your glutes, so your bottom muscles, to be as relaxed as possible. So if somebody's observing you doing it, they shouldn't see anything moving. So I'm doing mine now, and you would have no idea. I'm continuing to be able to talk to you, keep breathing, and my tummy and my shoulders haven't sort of lifted up off the seat because of the wrong engagement of the wrong muscles. You can let that relax if you've been practicing that. And you want to be able to hold it for at least 10 seconds, ideally, and then let it fully relax before you do your next 10-second hold. Sometimes in this postnatal population, particularly in that first 6 weeks, the connection and the ability to even find that muscle may well have become disrupted or a little bit poorer in its ability to find it. So the connection might be the first thing that they work on, and that's particularly so if there's any pain in the area. Pain will really inhibit the brain's ability to find muscles. So you only want to encourage a postnatal woman to start doing them when the pain has settled in that area, and by doing them you are not inducing or creating any pain by doing that squeeze. But if that's all okay, then they should commence them as soon as possible after birth. And the gold standard, or the idea, is that they would be able to do 10-second holds and then 10 quick contractions. And that quick contraction is just bringing it on and then letting it fully relax before you do your next on. The Squeezy app, which is linked in this presentation, is a really good way to get that reminder of doing them. And the evidence has shown that it's really important that women are encouraged to do their pelvic floor exercises, regardless of how they deliver, for the first year postnatally, to help with tone and even that sort of muscle retraining neural pathway. Any questions on that at all, about how to do your pelvic floor exercises or some of the advice to give? We'll go through that in a little bit as well, but the advice to give on pelvic floor exercises.
Nothing in the chat at the moment.
Thank you, Penny. So the muscle provides function for our bladder function. It gives us our ability to control urine, to sense the urge, and to control the urge, and it provides urethral support as well. It gives us our bowel function, the control of the bowels, the ability to control the urge when we get a bowel, the feeling of needing to go and empty our bowels. It helps us with defecation, so it actually helps in the passing of stool, and it allows us to control wind and to pass wind as well. It gives us our sexual function, both arousal, the ability to tolerate penetration, and the ability to orgasm. And it provides that sort of upward lift and support of the pelvic organs, and it provides a little bit of some stability for the anterior and the posterior joints, but not loads. Our more external pelvic muscles actually are much more important to be doing that, but it's an important thing to consider within the whole area, and with things that might have changed. So these are really, and again, I know that you don't have the time to go into these functions in huge detail, but this is definitely an area I would spend a lot of my the time with a woman when I'm seeing them at that sort of 6 to 8 week postnatal mark. I will explore and talk about their bladder function, their bowel function, their sexual function, and their sort of supported feeling within their pelvis, or any feeling of heaviness or dragging, a lot, just regardless of how they've delivered. So we know that it's the pregnancy that changes the muscle the most, really, and that's why, yeah, we want to just be exploring this and these functions in that first sort of 6 weeks. So dysfunction will and can look like urinary and or fecal incontinence, urinary and or fecal urgency that is potentially difficult to defer, or they're struggling to hold, a heaviness, a pressure, a bulge, a dragging sensation within the pelvic area, which after vaginal delivery is quite common to feel that, particularly for sort of the first 2-3 weeks after delivery, but it's when that's maybe continuing, and or coming on with exercise, or they're noticing certain things that sort of are encouraging or are bringing that on, to be sort of asking about or exploring. Most women by 6 weeks won't have necessarily returned to intercourse, but if it's painful, then that's definitely something to flag up. I always say that sex should never be painful. Obviously, there are reasons, and there can be big reasons why sex is painful, but we shouldn't expect sex to be painful after having a baby. One of the most common reasons as to why sex could be uncomfortable after childbirth is possibly, well, 2 reasons. Tissues that have maybe gone through a tear, or a episiotomy, and that there's sort of secondary, even though that tissue may well be healed at 6 weeks, the tissue can sort of have secondary effects of that tissue tightening and just trying to protect the area a little bit more, which could be tender or painful when it's being pressed or touched. And vaginal dryness is a big one postnatally. The estrogen levels are very, very low in postnatal women, and particularly breastfeeding women. So for 6 to 8 months after a woman has given birth, if they're not breastfeeding, your estrogen levels will be starting to climb, but still be quite low. And in breastfeeding women, it will continue to be suppressed until they stop breastfeeding, and it could still then take 6 to 8 months for those estrogen levels to come back up to within a normal range. And estrogen is a really important hormone within our pelvis. Our pelvic tissue loves estrogen. It gives our tissue plumpness, lubrication, and generally a bit more rigidity. And so that loss of lubrication can cause sort of friction-based pain, and be a sort of a thing that women experience with intercourse. And I always say, if you have one episode of painful sex, you're much more likely to have another one, even if there wasn't necessarily a physical problem for that pain to happen, because you're anticipating it to be painful again. So I always say to women to do 3 things: to take their time with returning to having sex after intercourse, both in terms of time and also in the moment. The more prepared you are, the better that tissue will be lubricated and sort of get better blood flow. Get used to their own touch and sensation in and around that area. That might be with themselves or with their partner. Even after a C-section, getting used to the tissue around the C-section and then moving that touch down towards their vulva and their vagina can be a really useful thing to actually just educate themselves and that tissue into what sensation feels like. And then they can have a conversation with their partner to say, you know what, I'm still a little bit tender over here. Let's just give it a bit more time, or let's really try and do things slowly to just not shock that tissue into what is about to happen. And then use lube. So it's probably advice that you're giving out regularly, but I often say to put that lube in internally before they start having sex. And that could even be in the afternoon, if they know that they might try in the evening, because if all the walls of the vagina are better lubricated, then it's much more likely that sort of, if there is a friction dryness based problem, that it's going all the way through the length of the vagina, not just at the entrance. Any obstructive defecation, and that's where you need to assist yourself with pooing. That is something that can happen postnatally, particularly as a result of a change to the laxity of the walls of the vagina. And some women then find that they need to sort of assist themselves to help with defecation. Any vulval or pelvic pain and any coccyx pain. So those are the sort of big things to be just asking. And again, it's not that you need to then spend loads of time doing it, but I suppose it's then putting them in the direction of specialists or physios that might be able to then help them unravel and get some clearer answers as to why this might all be happening. So pelvic floor needs to be considered because it's actually, as I said, the pregnancy that can cause the weakening and the fatigue of their muscle on its own. So it's a sort of increased load and an increased workload on the pelvic floor during the pregnancy, and that load and that fatigue can then weaken that structure. In pregnancy, 1/3 of women can experience unintentional or involuntary loss of urine, and about 1/3 leak urine in the first 3 months after giving birth. And then you can have loss of wind, you can have lots of other sort of pelvic floor dysfunctions within that pregnancy. So even though that some of that might have resolved postnatally, it's not that necessarily the pelvic floor has then gone back to, okay, well, there's not a problem anymore. Dysfunction at any stage and whatever might have caused that dysfunction should always then be looked at, so that there's not then a prolonged or dysfunction that might be causing no symptoms and then causing problems in a subsequent pregnancy or a subsequent postnatal period. So yeah, it's really important, even if they're feeling fine at that 6-week check, it's quite important to ask, did you experience any pelvic floor dysfunction in your pregnancy as well? So from a pelvic health point of view, you can definitely give lots of good advice. You can help them to maybe start learning about their pelvic floor and how to engage it, like we went through in that practical session. But really, a women's health physiotherapist is the place and the person that that woman should be seeking help from. If the dysfunction is happening during pregnancy, then great. The earlier you can get them to see a women's health physio, the better. But if it's in that postnatal period, then referring on for them too. The Squeezy app, like I said, which is linked here, is a really great educational tool, and can be really useful to just get that person on board with learning about their pelvic floor and the regularity of how you should be doing your exercises. And then this directory here, the POGP, which is our sort of subgroup under the CSP, which is our overarching umbrella governing body. The POGP is a subgroup called the Pelvic Obstetric and Gynecological Physiotherapy Group. They have a directory of all private and NHS women's health trained physios. So if that woman in front of you is wanting to be a bit more proactive, get some help a bit quicker, then that would be the sort of directory you could direct them to find a physio local to them that might be able to help them with that. The waiting times are definitely improving in Bristol. I don't know about the rest of the southwest, but I do know that about pre-COVID, we were trying to see women in the NHS in Bristol urgently with a postnatal problem within 2 weeks. I know that COVID definitely added a lot more pressure onto the NHS, and that went up to probably about 3 months. But I think that has come back down to within about 2 weeks. So a postnatal woman experiencing pelvic floor dysfunction should be a priority in the triaging process within the NHS system. So yeah, that it should be a sort of quick and easy way for women to access pelvic health input.
Rosie, before you just move on a second,
Yeah.
we've had someone, Zoe's commented, I've had a couple of patients asking whether pelvic floor exercises like Perifit are safe or good options. Don't know what to advise them. Perifit, Perifit.
Yeah, so there are two types of sort of machines out on the market for pelvic floor help. There's the Perifit and the LV, which would sit under a sort of biofeedback group of muscle trainers. So they would be inserted internally, and both machines pick up on, they have sort of pressure sensors within them, and they go in like a tampon, and on that sort of surface, they would pick up on pressure. And the pressure would then talk to an app on your phone, and you'd get this sort of moving game like sort of, you know, Nintendo game like sort of presentation of this thing moving up and down on your phone to say, yes, you're doing a squeeze and it's coming up to this sort of level of intensity, and yes, you're relaxing and it's coming down to here. So there is a place for them. They can be really useful, but they aren't going to necessarily get that muscle stronger. So it's the act that they're encouraging you, and you're maybe being a bit more compliant with doing your pelvic floor exercises because you're getting some feedback in the shape of your app and what you're seeing on your screen. I have had a number of women who use them and their pelvic floor symptoms aren't improving, and when I assess them, they have been doing their pelvic floor exercises wrong, and the device and the machine has been picking up on pressure from their abdomen or their glutes rather than their pelvic floor. Now, both devices, the Perifit and the LV, are getting better at sensing wrong squeezes, but they're still not perfect. So yes, use them, and if somebody has already bought one, they can be very expensive. They're in the region of about £180. They then, you know, and they seem to be helping their symptoms. Great, they're probably doing the right thing and they're getting this good compliance with doing their exercises, but they're not necessarily a one size fits all for learning how to do your pelvic floor exercises and necessarily doing the right thing. The other group of devices that is out there is called neuromuscular electrical stimulators, NMES. The Kegel 8 is the biggest one that has got a sort of the biggest one on the market, really, and I would only recommend them for women that have got an Oxford grading scale strength within their pelvic floor of a 0 to a 1 out of 5. So they've got very, very poor connection from their brain to the muscle, and they're not really getting any idea of how to improve that or get it stronger. So the neuromuscular electrical stimulator would be inserted internally, and then little electrical stimulations would stimulate the muscle to create a contraction, which then that patient would feel and they could join in with it. And in them joining in, they're going to start improving that neuromuscular connection, getting that muscle stronger. So you would want to wean out of using it, but they're only really beneficial for, yeah, that sort of very, very weak, very, very poor muscle function. And really, they would be, you'd want to, from a physio point of view, I would want to have tried a few other things before I use that to see if we can get that connection going first. So yeah, hope that answers that question. A bit of a long-winded way of going around it. Moving on, what can you do as a GP? Early referral to the Women's Health Physiotherapy team, make them aware of that POGP website, make them aware of that Squeezy app website, and encourage to seek help. It's common, but it's definitely not normal. There are other things that we'll go through as well that might be birth specific that you could also advise. So you're going to know all of this, but it's just a recap about vaginal deliveries and the sort of grazes, tears, and episiotomies that we might sustain with certain vaginal deliveries. So this area in our pelvic region between our back passage and pubic bone at the front of the pelvis widens during pregnancy and increases significantly after a vaginal delivery. And they've found through research that it can take up to 12 months to reduce in size to that of someone who had a C-section delivery. So it and generally the area doesn't return to their prenatal size. So it takes a long time for this tissue to recoil, and again at 6 weeks you're not going to see that that tissue has gone back down to a normal size or their pre-pregnancy normal. So it's again having that advice that or giving them that information that you're assessing them if they're requesting that you assess them vaginally, that you're assessing them in a very, very acute phase of their healing, and there's going to be a lot that changes within the next 6 to 12 months. I always explain to the women that I'm seeing that from a gynecologist point of view, you'll know this from your referrals, a gynecologist wouldn't really want to see them until at least 6 months, because they know that that tissue will go through a huge amount between birth and 6 months, and that they may be suggesting or seeing things a bit prematurely if they're seeing them before 6 months. So it's just to give them that reassurance that it's not to sort of downplay what they're feeling and what they're experiencing, but just to give them that reassurance that a lot will change week on week in that first 6 months, and even from 6 months to a year, from a sort of vaginal point of view. So the women that have experienced grazes, grade 1 or grade 2 tears are least likely to experience pelvic floor dysfunction immediately following birth, and also in the long term as well. Grade 2 tears, generally, they do go into the muscle belly, but the muscle can recover relatively easily from that with, again, the right pelvic floor advice and doing their pelvic floor exercises. The thing that I would say is most common to happen with grazes, grade 1 or grade 2 tears, is some discomfort with the healing and sort of managing that scar site. And there can be some things that we'll talk about that can be really useful with that. Offloading the area, so trying not to have direct pressure on it, can be really, really beneficial to allow that tissue to heal. Moisturizer or some barrier creams once that scar has healed fully and there's no risk of infection, and maybe some estrogen, which we'll talk about as well, can be really beneficial. And then once the pain has settled, they should resume pelvic floor muscle exercises as soon as possible. So the vaginal deliveries with the grade 3 A's, B's and C's, or the 4th degree tears, all these women should be referred to the obstetric anal sphincter injury service or clinic. So that should be happening in hospital before they leave hospital, that referral should happen. But I have had a few women recently in Bristol who haven't had that referral made for them. So then I've been telling them to go to their GP to just make sure that that's been done, or if they can chase it. I don't know if that's the right thing to do, or they could also, if they've still got links to their midwife, that could also be organised that way. But it could be something that you just check up on for them at that 6-week point to just say, yeah, you're within the system, and that referral has been made. Within that service, it's a national service or a national incentive, and they should be routinely followed up by a physio at 6 weeks. A lot of the time that's happening on the phone at the moment. And then they should be seen by the obstetric team at 12 weeks. And that sometimes is a combined physio and obstetric appointment if they haven't been seen at 6 weeks by the physio. Every department, every hospital is a bit different with what they offer. And from that, they then may need a later referral into the anorectal team. And the risk is that they have an increase in that sort of bowel dysfunction later in life. This charity here, MASIC, is a really, really great charity to help women support their sort of physical and emotional needs if they've sustained a grade 3 or 4 fourth degree tear. And again, it can be something that you direct a woman to at that 6-week mark if they're willing and happy to be, talking about it, to just flag them and say that you might get lots more information from this charity about what you can be doing to be proactive to help the tear that you sustained. And again, with these ones, thinking about whether they need a birth debrief or if there's any sort of trauma associated with their birth, and just there's some really good charities. There used to be an amazing charity in Bristol called Bluebell. They've sadly folded and they're no longer operating, but there's lots of other charities, and I'll send Roger some links to some where you can just direct women to get a little bit more help, and lots of them are one-to-one conversations with either a trained therapist or actually mothers who have gone through similar things, and it's just sort of like a friendly network of discussions. So a forceps delivery was associated with significantly more pelvic organ prolapse, levator avulsions, larger hiatal areas than a vacuum or a normal non-instrument vaginal deliveries. And particularly in their longer term pelvic floor health. So women may not experience it at 6 weeks or 8 weeks or at 6 months or at a year, but they may then have a sort of, gradual decline of that pelvic floor health over time, and be more at risk of developing pelvic floor dysfunction later on in life. In Bristol, women who have delivered via forceps the pelvic health team in the hospitals try to see the women before they leave hospital and make them aware of the self-referral system within Bristol that they can refer into the women's health team, but that doesn't always happen. So it's worth speaking to women who have had forceps delivery at the 6-week mark to just say, you are more at risk of developing pelvic floor dysfunction. Here is the self-referral form for the pelvic health team, or you can refer them in yourself as well. So episiotomy care, the episiotomies normally happen on the mediolateral on the right side, and they can be associated with a decrease in pelvic floor muscle strength. They should be similar or create similar sort of injury as a grade 2 tear, but just depending on the length that they need to be and the sort of act of the procedure, they can then increase pelvic pain, minor sort of perineal lacerations, and they don't protect against urinary and anal incontinence or vaginal prolapse, unfortunately. The sort of priorities for care with episiotomies and for any of the tears are to reduce infection. So those peri bottles that sort of help to irrigate the area when you're urinating by just pouring water over the vulva and the vagina can be really, really useful to reduce any infection and any stinging with those those tears. Reduce pain on sitting. I'll show you a Coccyx cushion that I often really recommend for any woman that's had any vaginal trauma or any tears, because it just reduces that sort of pressure within that area, which helps that tissue to just heal so much better. And obviously sitting is a big part of that postnatal presentation because of feeding, breastfeeding, and trying to rest and recover really. Massage can be useful to just get that tissue moving a little bit better, but only from 6 weeks at the earliest, and only if that scar is looking really well healed and not sort of irritated in any way. Massage sometimes can cause a little bit more irritation, and so it needs to be done with like but you can just make somebody aware that that could be useful for them. Some barrier cream can be really helpful, particularly where the episiotomy is. It can create quite a lot of friction when that woman's walking because of where it sits. And if there's that reduction in estrogen, the area's a little bit drier, then actually they can get a lot of like friction-based pain or irritation on that scar. So I often just recommend a Eucerin cream, so the French brand Eucerin, or a Vaseline type cream that you just pop over the scar once it's fully healed, and that just reduces any of that sort of skin to skin irritation that you might get, which might cause some pain or problems. Really try and get on board with reducing their constipation. Any pressure into that area can just disrupt the scar healing and just cause more problems. And I definitely see a lot more scar granulation presentation with the women that have said, oh yeah, I have been constipated for a few weeks, and that scar has just been challenged and really has found it hard to get that healing going. And then, as always, commence that pelvic floor training as soon as possible. So comfort is really important, rest, support. This is the cushion I normally recommend, not the donut cushions. This just means that that perineal area will get that sort of offloading much better with a cushion like that. Make that woman aware of that referral system if there is one in place where you are, particularly if they've had that forceps delivery. Ensure that they're known by the OASIS team, and then get them looking after their pelvic floor and starting those pelvic floor exercises as soon as possible. Estrogen. So estrogen is a very confusing and what's the word? Conflicting area, I suppose, from a postnatal breastfeeding population. The reason is because there isn't any evidence to support it. It's very, very hard from an ethics point of view to get good research in breastfeeding women. But there is some anecdotal evidence, and there's some very low level evidence to say that it can be a useful thing to prescribe, and it shouldn't affect milk supply if it's being used after the 6-week mark. So the link below here is the one that I often go to sort of direct anyone that might be prescribing to just read a little bit more about it. But the reason it can be useful, particularly with tissue healing from an episiotomy and a tear point of view, is that obviously this estrogen levels drop postnatally and they'll be suppressed whilst that woman is breastfeeding. And prolactin, which you need to allow breastfeeding to happen, exerts an antagonist effect on estrogen production. So you can get sort of shrunken labia, reduced secretions, erythema and inflammation in that area, which just disrupt and potentially prolong how well that tissue is going to be healing and getting better. And our tissue, like I said, loves estrogen. So what I normally recommend for women to try is to try a vaginal moisturizer. There's some really great ones on the market. The Yes brand have got a lovely vaginal moisturizer that is really, really, really useful in postnatal women. The Silk brand have got one as well. So to try those, see if that has any benefit to their symptoms or their tissue. And if it does, or if it's reducing or it sort of isn't quite good enough, then to maybe speak to the GP and ask whether a vaginal estrogen prescription is something worth considering. So from a C-section point of view, the sort of main thing to be considering is the scar healing, basically, and just seeing how it is. So the incision goes through 7 layers of tissue, and the incision is made sort of vertically rather than horizontally through those abdominal muscles. So the abdominal muscles are never cut, which is one big concern that I see a lot of women worried about, is that their abdominal muscles have been cut horizontally, which is not the case. You go through that sort of white linear alba structure, and then that's sewn back together. So yeah, it's relatively straightforward and causes very little disruption to the muscles, but it still can do. The sort of big thing that I say to women who have had a C-section delivery is to just be mindful about the healing timeframes. So any scar that has been created has generally reached about 50% of its tensile strength by 6 weeks, and it's much closer to sort of 80 to 90% by 12 weeks. So when they've got to 6 weeks and they think, great, I've done all the healing that I need to do, I'll start putting my running shoes on and going for a run, then I just sort of say to them, well, yeah, you could do, but your scar is only really at 50% of its maximal ability. So it's going to be quite stressed if you're then trying to ask a lot of it in from that 6 to 12 week mark. And that could create more scar disruption, more scar, the scar to thicken, and that then causes a sort of longer complications further down the line. So yes, they may well be feeling a lot better at 6 weeks. The scar might look quite good, but it's really that 6 to 12 week mark that's actually quite important for them to just not jump the gun a little bit. So this should say women who have birthed by C-section are still at risk of developing pelvic floor muscle dysfunction. The tissue can change in response to the incision, and the symptoms are much more in line with a sort of increase in pelvic tone or pelvic floor sort of activity, where you get dyspareunia, painful sex, urgency with your bladder and potentially your bowel, bladder frequency, and then maybe that sort of coccyx pain as well. So it's still worth educating those women about pelvic floor dysfunction, and maybe just thinking more about that sort of overactivity presentation rather than a sort of laxity presentation. So lots of rest, limit lifting for definitely 6 weeks. You might not be seeing them before that point anyway, but really reinforce this point about that total healing is more likely to take up to 12 weeks, and that's why they still want to be conservative with their approach of what they're doing. Exercise obviously can start at 6 weeks, but it needs to be gentle and sort of more rehabilitative and more sort of connecting or connection based in terms of getting the brain to switch on certain muscles from that 6 to 12 week. There's a lot of talk about C-section massage, and there is definitely a place for it, but I wouldn't do it before 6 weeks, and I'm also a little bit conservative with doing it before 12 weeks really as well. Sometimes over egging the scar massage can again cause more scar disruption, cause the scar to thicken, and yeah, just cause bigger problems. So the thing that I do recommend from 6 weeks is the use of silicone strips. They're very, very well evidence-based to promote the benefit of trying to flatten the scar and also improve the colouring of the scar, because what they do is they sort of allow hydration to go down into the deeper layers of the scar over a long period of time, and that can be really, really good for scar healing. Diastasis. So we did do a whole presentation on this a few weeks ago. So if you haven't seen it, then you can always go back and look at that recording. So I won't touch on this too much, but it's just to be aware of it. It's a normal presentation that happens in 100% of women in their 3rd trimester. And normally by about 8 weeks postnatally, the tissue will have recoiled to probably where it's going to sit, where it's as much healing it's going to do naturally. And normally by 8 weeks, 2/3 of women, that separation will have come back to within normal ranges. Normal ranges anything between 0.5 and 2 centimeters of width. And in 1/3 of women, you might find that gap and the diastasis and the condition of that tissue is not as good as the 2/3 of women where it's come back to normal. So it's something to be aware of, and it will be trying to sort of recoil with up until that 8 weeks. So that's what we've just said there. These two links at below, Granier Donnelly and Munira Houdani, are really, really good sources. Granier is an Irish physio and Munira is a Canadian physio, and they've got some really great resources on their websites for patients to actually learn a lot more about diastasis and to start getting that ball rolling if they think it's something that is a concern for them. So yeah, we look at the width, the depth, the tension of the tissue, and doming is something that is talked about a lot with diastasis, but we're not sort of, I'm more interested in the function of the tissue rather than whether it's doming, because doming is something that can happen just as you do normal daily things. So it's making them not focus necessarily on the width, but think about that tissue as a whole and how it presents, as a whole. So the thing that needs to be done for it is it's a very individualized approach. So again, referring to physios is always a good place to start. It would have to be a pelvic health physio that is that would be the best referral to create. Other musculoskeletal physios, it's not really an area of expertise that they would know anything about. So it would have to be referred into the women's health team. You want to be progressively and optimally loading that abdominal wall to then start seeing changes within that tissue. And you're not looking to necessarily close the gap, you're just wanting to improve the function of that abdominal wall. As I say, there's another presentation that we did a few weeks ago that will help you to understand a lot more about this. So the big question that you probably get asked, and I'm just conscious of time, so is returning to exercise. So gentle exercise absolutely can commence even within the first few weeks of birth, before 6 weeks, but it has to be gentle. And they have to be really monitoring any pelvic floor dysfunction or making sure that it's not worsening pain or symptoms or anything like that. This is generally the sort of in the pyramid that you would want to go through, is setting your foundations, returning to good form with basic movement, adding in low impact, and then adding in your high impact. This chart, if I just skip ahead here, is really, really useful, and I'll send you the link to it, of just giving you that really basic outline of what exercises are sort of to be expected at what stage. And again, you could forward this on to your patients so that they've got a really good understanding of what basic is and what the progression might look like. So by 6 weeks, you're sort of starting to think about that scar mobilization. You might be starting to do a little bit more walking. You're adding in sort of some low impact exercise, maybe adding in some sort of deadlifting, some squatting. By 7 to 8 weeks, you're maybe doing your swimming. You can swim as long as your lochia you've had 7 days of no lochia, you can be starting to swim. And then by 12 weeks and beyond, it's not until 12 weeks that you want to be thinking about returning to impact. And that's from this sort of tissue time healing framework that we've been talking about. Tissues really aren't capable of coping with the demands of impact until 12 weeks, until they've really got that 80 to 90% of their tensile strength to cope with it. Just going to go through this, which is in the same article, which I'll send you, is a really good way of sort of screening whether somebody is ready to start running. And this has been designed by Granier Donnelly, who's the diastasis expert as well, and 2 other physios. So is the mother 3 months? Yes or no? And then have they had a pelvic floor screen via a physio? Yes or no? What's their sort of nutrition and sort of mental health state like? Have they gone through sort of an impact screening? Have they had their sort of core and trunk assessed from a diastasis point of view? What's their sort of sleep like? What's their scar tissue like? Are they breastfeeding? have they done some strength tests, and is their BMI low enough? An increase in BMI is going to put additional stress on the joints and just will make running a little bit harder. And then if they pass that screening, if so, then they could start a return to running with a Couch 5K. And if not, then just start a rehab program to address where those dysfunctions might be, or whether that lack of strength might be as well. So yeah, it's not as easy as at 6 weeks saying, great, you can start running. It's that sort of, yes, running is on the agenda, but probably not until 3 to 6 months postnatally. And you have to do certain things to sort of get up to that point as well. Just make sure. Yeah, so that PDF there has come from the Return to Running Guidelines, which are linked here, which are a really, really good source to get back to or look at and help you make the decision about whether somebody is ready to start running. So just finally, we'll just touch on postnatal lower back pain and coccyx pain. It's very multifaceted as to why it happens. It's not always down to a weak core, but it's more likely to be a weak core that isn't optimally working, which could be as a result of the pregnancy, possibly a diastasis, and possibly like a C-section incision that has caused a disruption to that core and how it works, or a repetitive loading pattern, which is really common with postnatal women. Think about the referral to MSK physio, or if the women's health team within your area accept referrals for lower back pain, then that would be the place to send them as well. And coccyx pain is also very common, particularly with women who have had a prolonged labour, an epidural, where they may not have sensed or been aware of that sort of real pressure within their pelvis during labour, or an assisted delivery with forceps or ventouse. Sitting can really aggravate that area, which is obviously very common postnatally. So trying to think about advising them on that coccyx cushion or offloading the area, even like 2 rolled up tea towels put under each thigh can be really useful to just offload that area. And unfortunately, they can take a really long time to settle because they just don't really ever get any let up from additional pressure. So just giving them that advice that it's probably going to be a bit of a long road, but just try and get on top of it the sooner that they can. So we've gone through this, but yeah, where to refer people to. So women's health teams, both from NHS and privately, depending on your sort of wait times within your area. The Oasis Clinic if they need it. The POGP for the website of list of NHS and private web physios. The Squeezy app to get them to start doing their pelvic floor exercises. This bumps and burpees is, and I know that you may not be able to suggest things from your own sort of practice point of view, but it's a really, really great exercise plan that is nice and steady and progressive, and it gets them up to sort of that sort of home-based HIIT style workouts over a 12-week plan. Personal trainers, there's lots of really good ones in Bristol if you're around here, but they're a really good option, particularly if they're women's health trained or pre and postnatal trained, a really good option to get that more like individualized approach. And I work a lot with some of the PTs in Bristol to sort of just get women moving and feeling confident with movement after pregnancy. So always remember to look at that woman holistically. Consider optimizing that vaginal tissue, healing timeframes, scar management, both from a vaginal point of view and a C-section point of view. Consider that estrogen and how it might help that vaginal health. It's not always essential, but it's definitely something that I'm recommending a lot more, and I'm seeing real benefits to women who have then taken or been prescribed estrogen vaginally. Pelvic health and the pelvic floor education is crucial for every woman. And always remember to encourage that sort of gradual progression with exercise and with supervision if possible. And getting moving and feeling confident with movement is so key at this stage of life to sort of help enable them to feel confident with moving, as they go through subsequent pregnancies, and particularly as they then go on to their next stage of life, which might be the menopause as well. So that's me done. There's definitely links. Oh, thank you for sharing the debunking diastasis one. There's definitely links to all the references within the presentation, which Roger will share with you. But I think we've got maybe a little bit of time if anyone's around for some questions. yeah, so if you
not at the moment. That was really helpful though, Rosie. Thank you. Really interesting. Certainly made me think about a few things.
oh good. Oh good, I'm glad the PeriFit one was answered.
Are you happy for us to share the slides with our teams if we've got anyone that think it might be helpful?
Yeah, definitely. And a lot of the links are linked in there. I'll just share the what were the ones I was going to share. Yeah, I'll have a little think about some of the other links that I mentioned, but I hadn't linked in there, that I will share as well.
Cool. Okay, I can't see any further questions. Thanks, Rosie. That was really helpful. Thanks, Penny, for fielding the questions. We put the link in the chat to the debunking diastasis video as well, so people can access that, and we'll circulate the all the other materials as soon as we can.
Amazing.
Thanks, everybody.
Thank you.
There we go.